There's actually 20 million people living with Parkinson's today, and that number is due to double by 2050.
Welcome back to Patient in the Room. Today we're talking about Parkinson's, and I'm joined today by Dr. Kit Wu. Welcome onto the podcast.
Thank you so much. It's a pleasure to be here.
Do you want to give us a little bit of background around what you do, what you specialise in?
Yeah, sure. I am a consultant neurologist, and my specialty is in movement disorders. There's one particular condition that I treat quite commonly that makes up what we call the bread and butter of my work, and that is Parkinson's. And I would love to have the opportunity to talk about that in our podcast today.
I was actually reading when I was researching for this episode that around 153,000 people are currently living with Parkinson's in the UK. I didn't realise so many people kind of lived with this in the UK.
Yes, it's true. It is under-recognised. We don't talk about it enough. But there's actually 20 million people living with Parkinson's today, and that number is due to double by 2050. So it is a remarkably growing condition due to a number of factors such as an ageing population. And we need to match the treatment and the management strategy to that growing exponentially.
Maybe let's start with what actually is Parkinson's disease.
Yeah, Parkinson's is a progressive neurodegenerative condition and one of the most common neurological disorders, as I mentioned. It was first described by a London doctor in the 1800s, a London doctor called James Parkinson, and hence it carries its name. At a biological level, it's about the loss of dopaminergic cells, or the loss of dopamine from the brain cells in a specific part of the brain called the substantia nigra. These cells produce dopamine, and it is a chemical messenger that is essential for smooth movements. As these cells degenerate, the classic symptoms begin to emerge, typically associated with tremor, stiffness. It's a brain condition, but it's also a whole systems condition. It affects the whole person, it affects the family and relationship and the quality of life as well.
So I think when most people think about Parkinson's, for myself as well, I think of that kind of the hand tremor. That's kind of where my mind immediately goes. Is that the most common symptom you'd kind of start to see?
It is a very common picture, and it is what most people associate with Parkinson's disease, but it is an incomplete picture. And that incompleteness is actually one of the reasons why many people are diagnosed later than they should be. Tremor is visible, as you can see, and it is what people notice. But not everyone with Parkinson's has a prominent tremor. And crucially, not all tremors are attributed to Parkinson's disease. In my clinic, the majority of tremors turns out to be something else, more commonly like essential tremor, which is a completely different condition. So if you do have a shaking hand, please don't panic, but get it properly assessed and don't wait.
So if potentially the hand shaking isn't always necessarily prescribed to Parkinson's, what other common symptoms might come along with the hand tremor, come instead of?
Yes, absolutely. And that is a really good question because the essential diagnostic triad, which we have been using for diagnosis of Parkinson's disease, include bradykinesia, which is slowness in movement, and plus at least either tremor or rigidity, which is stiffness in the limbs. So symptoms typically start on one side of the body. But here's what I really want our listeners to understand. In many people, particularly women, as we'll come to later, the earliest signs of tremor, the earliest signs of Parkinson's can predate any tremor of movement symptoms, and sometimes by more than a decade. Things like loss of smell, persistent low mood, depression, chronic constipation, vivid dreams or acting out dreams, urinary symptoms, fatigue. These are non-motor symptoms that can predate tremor itself by up to 10 years. And that window of diagnosis is so precious because early treatment and early management can really change the course of their condition.
And so if I have Parkinson's within my family, first generation family, second, etc., am I at a higher risk of developing Parkinson's?
Yeah, it's a really common question. And the truth is, it does increase your risk of developing Parkinson's by about twice, doubles the risk. But the vast majority of people who develop it have no family history at all. Having a close relationship can increase your risk, but the number is so small that at the end, it's still a very small chance of you developing Parkinson's. And the bottom line is that most people with a family member who has Parkinson's never develop the condition themselves.
And you mentioned kind of like non-motor symptoms there, particularly, like a decade before potential diagnosis. That sounds like as someone who might be developing Parkinson's, how do we look out for them? You mentioned kind of constipation, vivid dreams. These are all things that could be associated with other conditions as well.
That's right. It's a really disparate range of symptoms. And interestingly, my PhD was focused on this, so I've been thinking about it for 20 years. The non-motor symptoms is a group that often precedes tremors or motor symptoms. It can include loss of sense of smell, persistent low mood depression, constipation, acting out dreams, urinary symptoms. But in that prodromal window, people are being seen by GPs, psychiatrists, gastro, doctors, but nobody actually connects the dots together. And that window, we lose precious years. It is important for someone to pick it out early. So if you do suspect movement disorder, or if you experience symptoms that doesn't quite fit or you don't feel it's right, it is really good to seek help early, particularly thinking about neurological conditions that can combine a number of symptoms.
So if someone is kind of having maybe 2 or 3 of these symptoms, I guess kind of writing them down and drawing your own kind of dots between them. And so if you've drawn the dots between these, appearing different symptoms, who is best to go and kind of say like, hey, look, I've got 3 of these symptoms, they're all coming at once. I think I need to go and see a neurologist. Would you go for a GP?
Yes, GP can always be a first port of call, and that would be sensible and the logical thing to do. If the symptoms are persistent, if they cluster together, and that is why I always advise patients to keep a symptom diary, because symptoms can change and it can be due to a number of factors. So it's a really useful way. If the symptoms are persistent and they get worse, then it is definitely worth seeking an opinion.
And with these symptoms, so say kind of like loss of smell, sleep disturbance, things like that, would we expect them with Parkinson's to kind of last? Do they come and go? Like, do you suddenly one day wake up and your smell slightly more back? And
yes, people normally notice the loss of sense of smell quite suddenly, but associate it with some sort of event in their life. Often it would be someone asking, "Oh, can you smell this?" and they can't. And then the sleeping symptoms is interesting. If they have a bed partner, then often the bed partner will report that. So it's kind of linking those together. And those two are actually essentially red flags for potential Parkinson's. They are associated with Parkinson's disease.
And how long should someone kind of wait for if someone wakes up, they've lost their sense of smell, they've been having a little bit of trouble sleeping?
Yes, I think definitely get a specialist opinion. I mean, a GP as the first port of call, and then trying to get a specialist opinion. It is associated with Parkinson's specifically, those two particular combination of symptoms. So it's better to get help early.
And when I was kind of reading about this, I came across the DaTscan.
Yes, DaTscan. So it's yes, you've said it correctly. It stands for dopamine transporter scan. And it is a specialized functional brain imaging test looking at dopamine transporter levels, so the receptors that transport the dopamine chemicals themselves. It can be helpful when there is a genuine diagnostic uncertainty, for example, whether a patient has essential tremor or whether they have Parkinson's disease. But it's not always necessary. If someone presents clinically, classically with the Parkinson's symptoms, I'd rather start them on treatment without delay than wait for the brain scan, because then I can see how they respond. That it's in itself, the observation that someone improves on treatment is a supportive factor for the diagnosis of Parkinson's.
And so if someone was going for that scan, what does that scan involve? Like, how do you MRI your brain?
It's similar to a CT or an MRI in that case, in the sense that you lie flat on a bed. They inject a small amount of dye in a vein in your arm, and you just lie still for about 40-45 minutes. It's not as noisy as the MRI scan, so normally it's quite calm. And interestingly, the images that show up, they light up in different colors. And that area of the brain which lights up in a DaTscan is the substantia nigra. It looks like two commas facing each other.
Oh,
yes.
cool.
And so by comparing how much they light up compared to a group of healthy controls, we can then have a good indication of whether patients have lost the number of dopamine cells that would qualify for a potential diagnosis of Parkinson's.
And that's so cool. I've seen like on TV, you know, where people kind of like map out different emotions and stuff in the brain.
It's similar to that.
Are there any other conditions where potentially a lack of dopamine would flag in the brain as well?
It can, but not in a DaTscan. DaTscan particularly is sensitive to Parkinson's, so that's what we use it for. But another similar type of brain scan called the functional magnetic resonance imaging, FMRI, they can detect changes in blood flow in response to an emotional event, or when you're looking at pictures that changes your emotion or ways of thinking or IQ tests. So that is really interesting. And that was what my PhD was based on, actually. Yeah, so it's very close to me.
Super cool.
Yeah.
And so when you're going in for this DaTscan for Parkinson's, would you be asked to look at different pictures, say different words?
No, you just have a dye. So it's a static scan.
Okay.
But you just look at, you just rest on the bed. And there is what looks like a donut, similar to a CT, and that measures the activity of the transporter molecules.
And so if someone goes for the scan or not goes for the scan, how long typically would a diagnosis take for someone?
So a diagnosis isn't actually based on a scan, and there is no single diagnostic test. There's no blood test. It is a clinical diagnosis such, based on the diagnostic criteria and also patient symptoms. And that's why it requires quite a nuanced approach by a specialist who has seen many, many cases over years to be able to give that diagnosis. DaTscan, MRI scan can help to support the diagnosis, but it won't make or break it.
And I guess, like, so from someone's first symptoms, you know, not tremor, potentially something that's not kind of neurological, what's the kind of time frame someone might be looking for to first diagnosis to treatment?
Yes, if it's not a motor symptom as such, like bradykinesia or tremor, it can actually take longer because that's what we describe as the prodromal phase. The non-motor symptoms, they're so disparate and they're quite nebulous in the sense that, you know, we're not quite sure what system in the body that is affected by it. And so it can take up to about 10 years in some cases. It's about joining the dots, really, about being able to cluster those symptoms together and say, actually, you might have potential Parkinson's. And then on a examination by an experienced neurologist, you can often pick out some of the tremors or bradykinesia, the motor symptoms, earlier on with certain tasks.
And I just wanted to touch on as well young onset Parkinson's. So when I was kind of reading this, is people classed as under 50, under 40. Is this quite rare or is it more common?
Yeah, not as rare as you would expect. So 1 in 20 people under 40 are diagnosed with Parkinson's. So it's actually young onsets. You're right, the definition is under 50, but 1 in 20 is under 40. And young onset tend to have a different phenotypic profile, meaning that they present slightly differently. They also have a stronger genetic predisposition, but it carries with its very different specific challenges. Young onset patients, they tend to be at the peak of their career, so it can impact that. Childcare, physical fitness, relationships, identity. The best example is Michael J. Fox. He was diagnosed age 29. He's now in his 60s, and he's still very active. He's still very engaged. And this is what I would like our listeners to understand. And the message is that with good care, early diagnosis, careful treatment, most patients can have a very meaningful life.
And so there's no cure for Parkinson's. I think that can hit quite hard, kind of sitting there, potentially having that diagnosis and being told there is no cure for this. But I guess it's kind of management of each symptom as and when they come up.
Yeah.
Or can we predict symptoms that might come up?
Yes, potentially. Yes, absolutely. I know there is no cure, and that is the honest truth. But there are a number of conditions that we manage in medicine extremely well, which doesn't have a cure. The best example is something like diabetes. Mm-hmm. We have a number of medication. Patients need to do a number of lifestyle strategy changes, and it can potentially reverse their symptoms. And this is what I would like to compare Parkinson's with. It is a similar treatment pathway. There is no cure. Treatment is very effective. Levodopa remains the gold standard of treatment. It is replaces the dopamine that is lost in the brain. And it's been around for decades. It's a very reliable treatment. It still works brilliantly. So I sometimes describe that as turning back the clock. For someone who has symptoms, they start to improve in their movement, their quality of life changes. And that's sort of what we call the honeymoon period within the first few years. It is truly transformative. And again, I'm pressing on the early diagnosis and the early symptom recognition. We've got a number of armory in our Parkinson's treatment pockets. Another option is dopamine agonist, which stimulates the body's dopamine cells to produce more of that chemical. Monoamine oxidase B inhibitor, which slows the breakdown of dopamine in the body. And also amantadine, which is used later on to manage some of the potential side effects. The important thing is this: most people live well with Parkinson's, even decades after diagnosis. You're not dealing with Parkinson 30 years ago.
And what does that treatment realistically look like for someone? Is it hospital visits every week, 2 weeks? Is it an injection?
So it starts with a diagnosis. Mm-hmm. So before that, you've got to recognize your symptoms so that we can actually make a diagnosis. After diagnosis, we look at a number of different domains. So medication is just one part of the puzzle. In terms of medication, it ranges from once a day to as regular as every 3 hours, 2 to 3 hours later on in the condition. And they may need to take 2 or 3 medications in order to control their symptoms. Medication aside, lifestyle exercise is one of the biggest changes that patients can make to improve their life. Gut is very important, gut health, because there is now a really interesting area of research which links the gut with development and worsening of Parkinson's disease. In particularly, patients with Parkinson's have chronic constipation, and so that link is even more emphasized. Mm-hmm. And then we work with a number of multidisciplinary team individuals, physios that can help with ensuring safe balance, safe walking, and reinforcing the exercise regime. Occupational therapists that can help with improving ability to work and function around the home. And then speech therapists, dietitians, etc.
And so when I was kind of looking at this, I came across the kind of phrase wearing off.
Yes.
What does that actually mean in practice?
Yeah, so wearing off is one of the most important things to understand and to map out carefully for each patient. Everyone is different, but as Parkinson progresses, the window of time that levodopa, the treatment, works effectively becomes smaller. A patient who, for example, previously felt well after medication for 4 to 5 hours may then find symptoms returning after 2 or 3 hours. And this creates what we call an on-off cycle, where the period where the medication is working and the period isn't. So that can then lead to motor symptom fluctuation, which we call motor fluctuations. Everyone experiences this differently, and it's deeply personal. So some people may find that they switch off suddenly. and others feel the stiffness creeping back in. Some patients notice mood changes or anxiety in the time leading into an off period. But once we understand the personal pattern, and sometimes we use continuous monitoring to map out the relationship between medication and the wearing off, we can manage it properly. And often structure the medication regime alongside other factors like food, diet, sleep to smooth it out significantly.
And let's talk about deep brain stimulation. I read that this was a potential form of treatment. What actually does that mean?
It is a established form of treatment, and it has been approved by the National Institute of Clinical Excellence as an option. And it involves surgically implanted electrodes in specific brain regions, which then is connected to a battery, a pacemaker-like device under the skin. And it gives out electrical impulses, which basically stimulate the area of the brain that drives the motor symptoms. So it sounds very high-tech, and it is very exciting talking about it. It's also very effective for motor fluctuations and dyskinesia, but it only works in specific subgroup of patients. The best outcome are in people with good cognitive function, who responds well to levodopa but have significant wearing off, as you had mentioned earlier. It doesn't slow the underlying disease progress, but it dramatically improves quality of life. The decision is really complex. It requires the patient to go through multiple specialist assessments and careful conversation with the patient and the family.
And what does kind of general disease progression look like with someone?
Yeah, it's very variable because it depends when they get the diagnosis, along which journey they're on, and also how long they've had the symptoms before. In my clinic, I tend to once they've presented to my clinic, I tend to give them a diagnosis either at first consultation or shortly after. And then from then on, it's much more of a, here's how you manage your symptoms, here's the treatment you need, and then a regular review every 4 to 6 months. And so getting that diagnosis is important. In terms of the long-term view, people tend to live with it very well if the symptoms are managed. They have good quality of life that can be maintained. Most patients have a normal length of life expectancy, and most don't end up in wheelchairs.
And you touched on women earlier and how it presents differently. I'd love to explore how that presentation potentially at first is different.
Yeah, it's a fundamental difference. The evidence is clear, but the clinical system and the treatments that we have been using has been desperately slow to catch up. Most Parkinson's research are based on men, and that is as a result of the fact that it is a condition predominant in men in the ratio of around 2 to 1. But that statistical majority over historical research has shaped everything. The diagnostic framework, the treatment protocol, the standard dosing regimes that we use, they're largely built on male data. But approximately 1/3 are women, and that's why millions of women receiving care hasn't really had the best care designed for them.
With the kind of like level of dopamine that you would give someone and the treatment and stuff, why does it differ between men and women?
With the diagnosis itself, let me start with that. Women are diagnosed with Parkinson's later than men because the early symptoms are more non-motor based. So things like fatigue, anxiety, low mood, sleep disturbance, unexplained pain, despite going to see multiple specialists. These symptoms are often, as they tell me, attributed to fibromyalgia, chronic pain syndrome, brain fog from postmenopause, reactive depression. And so they end up seeing different specialists before coming to see me when they eventually develop some motor symptoms like tremor. By the time it appears, it's often quite late and significantly later than the diagnosis of men. In addition, there is that menopause period that women go through. So most patients, when they come to see me, they're already postmenopausal, the estrogen level is low. But estrogen is really important because it influences dopamine pathways. So its decline can significantly affect how Parkinson's symptoms present and progress.
Yeah, I mean, that kind of just sounds like women's pain and symptoms being dismissed again and again, which unfortunately is something that seems to be a common theme when talking to specialists, unfortunately. But so when a woman goes through menopause, obviously that estrogen level drops.
Yes.
How does that interact with the dopamine in your brain?
So it reduces the amount of dopamine that is produced. And that's why some of the non-motor symptoms, dopamine is responsible for mood as well. They present more so with depression, low mood, brain fog. And these are the exact symptoms that the women who are postmenopausal are expected to tolerate.
Yeah.
So what is important, though, is to identify a number of these symptoms earlier on in order to be able to diagnose it as a potential neurological condition as well. So it is important to seek help early, either from the GP or a specialist like a neurologist who is experienced in understanding changes in a woman's body through the menopause and postmenopausal period and what neurological symptoms that can present, because there are valid treatments available which can improve their quality of life.
And so once a woman is diagnosed with Parkinson's, do the treatment options look different for her?
Yeah, it's a really important issue because it really does. So women's body are smaller, and therefore the dopamine medication in our bodies gets peaked much faster. So the nuance is that you need to take more regular doses, but a smaller dose, to help improve the smooth level of drug in a woman's body. If we adhere to the standard dosing 4 times a day in a relatively sort of standard regime, you get a much higher plasma concentration, and therefore complications can occur much faster. Dyskinesias particularly, which are sort of fidgety movements as a result of dopamine levels being too high, it presents as a false risk because it's a safety risk as well. So women in Parkinson's are prone to osteoporosis, and falls can mean fractures. This is really precision medicine. It's not overcautious, it's just accurate.
For a woman who maybe does have non-motor symptoms at the moment, how can she best advocate for herself if she's going into a GP appointment or a different specialist appointment?
Yeah, so first of all, recognising that you've got the number of symptoms and, as you had previously said, writing them down in a list, keeping a diary of when they occur, when she feels that it is in excess of what should be, for example, from her day-to-day activities, or she finds certain tasks during the day challenging, it's definitely worth bringing that to the attention of a medical professional.
And let's talk about careers and families and relationships. So, obviously living with a condition, whether that's Parkinson's, diabetes, etc., can take a toll on your career, your family, your relationships. What kind of advice do you usually give to your patients?
Yeah, so we welcome families to our consultations, and I'm really happy that they can have that support from the family, because Parkinson's doesn't just affect the person, it affects the whole family profoundly. In my experience, it's often the spouse or partner who carries the weight quietly and without nearly enough recognition. Before diagnosis, the carers are frequently the ones who notice something has changed, even when the person themselves can't recognize it. After diagnosis, they become the medication manager, the advocate, the appointment organizer with multiple hospital appointments, and the researcher on the condition, all whilst continuing to maybe manage their own career and holding the family life together. So whether it's a husband supporting the wife or a wife supporting her husband, the dedication in these partnerships is just remarkable. But that needs to be recognised, supported, and never taken for granted. The whole family needs to understand, because their observation matter.
And in terms of careers as well, have you seen people have kind of successful careers?
Yes, absolutely. Particularly with young onsets, once you recognise the condition and receive treatment, provide exercise, lifestyle advice, they often they continue to work for many years, even decades, successfully without any interruption. But it is important to manage that. And that requires a lot of detailed planning. And obviously day-to-day varies in a person's work life. So I tend to advocate that in terms of supporting them to continue to work to the extent that they feel comfortable. And then it's a good relationship and communication with their occupational department at work.
And in terms of kind of starting a family, obviously for a woman carrying a child, is that still possible with Parkinson's?
Pregnancy is a protected characteristic in our Equality Act. The presentation of Parkinson's tend to present later, and therefore most women who present are past their childbearing age already, so it's not such a big issue that we need to be aware of. With the young onset Parkinson's patients, I have managed those who have had children successfully. Levodopa, the medication itself, we don't have enough research actually because so few people are affected on the safety aspect. But most patients can carry pregnancy if they are of childbearing age.
And you kind of touched on earlier the long view, living well. You can live well with Parkinson's just as you can with diabetes. You kind of
Absolutely.
linked it with.
Yes.
Yeah.
So there's no cure, I'll be very honest with that, but it is highly treatable. With the right medication, the right exercise program, the right attention to the symptom profile, quality of life can be excellent. People continue to work. Life expectancy is now essentially normal. So the majority of my patients, most remain independent for years, even for decades. And I often tell my patients an analogy. So think of it or management of Parkinson's as you training as an athlete. You structure your sleep, your exercise, your nutrition around your medication. And then you monitor, you adjust, and you try and proactive manage and improve your symptoms. As I mentioned earlier, Michael J. Fox is a really good example of this. 30 years later, he's still working, supporting his charity work. And that is what is possible with optimal care for Parkinson's, yeah.
And just for someone who is listening, who has just been diagnosed or is kind of waiting for that diagnosis, what would you like to leave them with today?
So as someone who has just diagnosed with Parkinson's, the mindsets that I would like to leave with our listeners is that Parkinson's is a condition you live with. It can be managed extremely well. And that there is a good quality of life if you manage those symptoms and proactively manage them.
Well, this has been really, really, really interesting. It's definitely not something that I knew very much about myself, and I think it's just been such an interesting conversation, and learning that people can live with this disease and go on to have successful careers, families, I think is, really powerful for anyone listening today. So, Dr. Kitwu, thank you so much for your time.
Thank you.